Hey everybody, Dr. Leith here. Today I'm going to go over the somatic symptom disorders. These are really neat. I think you guys are going to enjoy this presentation. Let's get into it. Alright, so each of these requires that there be some sort of somatic aspect to the set of symptoms. So what is somatic? It's something physical with the body. So somatic symptom disorder, right? This is the first one there. Client has some sort of physical sensation in one or more body areas. And this can be pain, it can be pins and needles, it can be a numbness, but there is some sort of physical sensation that is not explained by an actual medical ailment, right? So I feel hurt, but we have ruled out, they've ruled out, a physician has ruled out any reason for that pain. And the person, your client, winds up spending an excessive amount of time worrying about it and reacting to the sensation. So let's look at the criteria here. One or more somatic symptoms, so that's the physical sensation, that are distressing. Excessive thoughts, feelings, or behaviors related to it. Right? So disproportionate or persistent thoughts about the seriousness. So I feel this pain in my wrist and I keep thinking about it all the time and I'm really worried about it, right? It's causing me a lot of distress. High level of anxiety about health or symptoms, right? So lots of checking and lots of time and energy devoted to those concerns. Specify if it's pain. So this used to be called pain disorder, and it was just, they really just kind of focused on those who felt pain. Now it can be any of those things. The other common one would be the pins and needles, like when something falls asleep. Specify if it's more than 6 months, and if there's more than one of these in there. So if you think about treatment for this, where is this person likely to go first? You're right, probably to a physician or a hospital, right? Nobody says, oh my God, my knee's killing me, let me go talk it out, right? They want to go figure out what the problem is, and typically what will happen is medically they'll do whatever examinations they need to do, ranging from the physical to maybe doing an MRI or something, and rule out that there is an actual physical or medical problem. And that physician is going to say, look, I think this is a psychological thing. And the person will come to us then, and then we're talking about, based on your theoretical orientation, the interpretation might be different, but what is it about that location? What is it, the meaning of that pain? What does it mean to you, and how to manage that discomfort? Illness anxiety disorder, also known as hypochondriasis, right? The person believes that they have caught something. And that's what separates this from obsessive compulsive disorder, right? Where there's lots of hand washing and fear of getting sick. With OCD, the concern is I'm preventing myself from catching something. With hypochondriasis, I already have it. And this person will have no symptoms or very minimal symptoms. So it might be that, for example, we all get sore throats, or many of us have had heartburn or indigestion or nasal congestion or something like that, and it's just it's uncomfortable, sure, but it's no more than what it is. But for this individual, it's throat cancer. I'm having a heart attack. I have an ulcer. It's some other very serious calamity that I'm dealing with. So they believe that they've had it or they already have it. Lots of anxiety over health and wellness. Lots of body checking and appraisal, meaning I'm looking at my body all the time. I know the location of every freckle, of every mole, of every blemish or mark on my body. And if I see something that maybe I didn't notice or it just looks different, then I'm hyper-focused on it, right? I don't remember that freckle being there. What is this? And there's preoccupation for 6 months. They don't have to focus on any specific one ailment or part of their body for the 6 months. It's just preoccupation with there's something wrong for 6 months. So let me ask you, do you think these individuals seek help or avoid help? Right, it's kind of down the middle. There are those who are constantly going to doctors to find validation, and what happens? That doctor says, oh, it's nothing, or it's just it's seasonal allergies, or here's some medication, and then they're on to the next thing, or if they don't like the response, they'll go find a different doctor. So, looking at the criteria, preoccupation with having acquired a serious illness, somatic symptoms are not present or they're only mild. There's a high level of anxiety about health, excessive health-related behaviors, maladaptive avoidance, if they do avoid hospital, because I don't want to know if something's wrong with me. That's the flip side of it. I don't go to the doctor because I don't want to know. The 6 months, and then specify, are they care-seeking or care-avoidant? There's a nice treatment plan posted on Blackboard about how to work through this. And typically the pattern with this is the person thinks they have something, then they go online, and what happens? Yes, they go to WebMD, and WebMD will say it's the worst possible thing, and that thing can result in death, right? So it just feeds into it. And now that we have cell phones and laptops and iPads and gizmos and stuff to constantly be connected, these guys can really get themselves worked up because I feel something and I'm on the bus or I'm at lunch and I can just pull out my phone and look this up and I'm off and running now, getting myself really worked up. And in some cases, that working up can cause some other somatic symptom, right, like a stomach ache, and now it's something else, and it becomes this model that feeds into itself. Conversion disorder. So the person has some kind of voluntary motor or sensory problem. So there is an actual physical problem that it's observable, but there's not a medical explanation or a neurological explanation. So you have to rule out, or they have to rule out, that there is an actual neurological issue here. And most of the time, this follows a really extreme and really sudden stressor. So let's look at the symptoms and then explain a little bit more. So one or more symptoms of an altered voluntary motor or sensory function. And so, for example, they have weakness or paralysis, like I can't move my left arm, abnormal movement, right? Their gait is off, like they're limping. I can't swallow. I can't speak right. Seizures. I can't feel things, see things. I lost my vision, or some combination. Those of you that are fans of the show King of the Hill might remember when Hank walked in on his elderly mother making passionate love with her equally elderly boyfriend. He went blind after following it, or after seeing it, right? And so that's what we're talking about. Really extreme, really sudden stressor is what we would expect. Like you see something very horrific or very traumatizing. And that, again, just like with the somatic symptom disorder, if someone experienced one of these, like I can't swallow or I can't shut my mouth or my hearing went away or something, chances are the first place they're going to go is a hospital or to their physician. That person's going to run whatever medical tests and say everything is fine, right? If there was a medical condition, that would be the explanation. But the physician rules out any actual neurological things, and then they're on their way to us, right, for talk therapy or for talk medicine. And we will work with them. If there is a trauma or if there is a stressor, then we work through that. And in theory, working through that traumatic or stressful experience would alleviate these symptoms. So a case study that I know of, this was not my client, but one of my professors when I was in grad school shared this example of a lady going to the dentist and having just a really bad, the fear of needles, fear of dentists. She goes, they're doing their work, they do the whole thing, and then she cannot close her mouth. It just won't. And so they do what they can at this dentist's office. They try giving it some time. They can't see anything wrong. They're working on it and decide that she needs to go to a hospital. She, of course, is getting increasingly worked up, right, which is probably feeding into the problem. Next door was my professor, who they said, "Hey, can you come just kind of talk to her because she is freaking out, right? What can you just? We're trying anything." And he went, and it was just a lot of, we're gonna go to the hospital and we're gonna get it figured out. You're gonna be okay. And slowly her jaw started moving a little bit at a time, right? It wasn't like, oh, I feel better and it shut, but she started to relax a little bit. This guy was just kind of soothing her, that the rapport, probably the voice, and the, maybe distracting her. And eventually she was able to kind of get control again over moving her mouth. So again, the key here is if you had a client and one of these things happened, we've got to rule out the medical condition part. And that can kind of be a little time intensive, but it's really important that we make sure it's not that before diagnosing this. Factitious disorder. Chances are you all have heard of this by a different name. Tell me if you can guess what it is. A client goes to great lengths to be perceived as ill, or they impose it on someone else and go to great lengths to make someone else look like they're very sick. And there's no obvious external reward. Any guesses? Sometimes it ends with by proxy. Yeah, Munchausen by proxy. Or Munchausen and Munchausen by proxy. So this is, let me make myself look like I have a condition, or make it look like my wife or my kids have a condition. And they can go to really great lengths, right? Like such as altering medical records, ingesting stuff or taking stuff that does actually make themselves sick, so it gets documented. Lots of attention on it, though, right? I'm pulling everybody back to look at me or look at my child or my spouse, and there's no external reward. Well, what does that mean? Well, that means this isn't someone who is faking sick to get something specific. So, for example, I'm sure we have all done this, or if you have kids, it's happened, right? My throat's sore. I can't go to school today, right? Or, dear Dr. Leith, oh my goodness, I was up all night with the flu. Can I please have an extension on the paper? They wrote the day that the paper is actually due. And so that would be an external reward. Faking being sick so someone can get like a scholarship or some kind of reward, right? That would be the external reward. There's none of that. It's done solely for the attention and validation of it all. And it can be imposed on another. And that's that's the situation where I'm doing it to my spouse or my child. So looking at the diagnosis, falsifying physical or psychological signs or symptoms, induction of injury or disease. So it might be that I put some kind of chemical in my kid's breakfast, or I lace my spouse's coffee with something. Not enough to kill anybody. I don't want that. But enough to look at how sick I am, or look how sick they are. Presenting himself or herself as ill to others. So again, lots of attention. This isn't just done. Doing it in secret would just be torture, right? Torturing the other person or torturing yourself. This is, I need the validation. I want you to see me. And if I'm doing it to myself, the reward is, look how brave he is. He's taking care of his family every day. He's going there and he's just pumping out those dope YouTube videos, and he does it all while he's sick too. If it's on another, it's look at how much he's taking care of that kid who's super sick, and he's still out there making those dope YouTube videos, right? So I want you to see how great I am for doing these things. Here's our criterion for the absence of obvious external rewards. And then here it is if it's imposed on another, again, by proxy. So this is a notoriously difficult disorder to treat because the lengths that they have gone to are very far. So this is not, oh, I'm sick, right? This is, I have gone from physician to physician to physician, feigning the ailments to a T. I'm ingesting stuff to actually increase whatever enzymes or levels or whatever. I'm really in there, and the person is way into this story. Now, here's the thing. You might be wondering, well, do they believe that they actually have it, such as with maybe a delusional disorder or with hypochondriasis? This person knows that they do not have it. They know that they don't have it. They want you to know that they do, right? And so it can be very difficult because we're not physicians. They have gone to many different physicians. There's lots of different records. They've altered them and things like that. And you're requesting it, and they're not under obligation to give it to you. So it can be difficult, right? And this can also really hurt if it's imposed on another. That can be very dangerous, right? Because somebody, they're just kind of doing the Wikipedia math of what's the maximum level of Vicodin I can give, a 50-year-old or something like that. So it can be difficult to treat this, but it is very serious. And if you suspected it was an elder or someone who had intellectual disability or developmental disability or a child, then that would trigger your responsibility to report. That's it for this one. It's a short set. Figured everybody needs a break. I hope everyone's well. Let's wrap up there. And as always, if you have questions, thoughts, or concerns, just let me know. I'll talk to you again soon. Bye.